So, dear colleagues, thank you for being here, especially at late Friday. Here is my presentation. All we know about the problem with hypertension is a huge burden. Billions of people worldwide have the disease, and nearly 1/3 of the adult population have hypertension. Is discussed nowadays not as disease alone, but at risk factor of cardiovascular death or disability. So we know that in more than 90% of the cases, the hypertension is so-called idiopathic, and we don't know the reason. Probably there are plenty of reasons for the hypertension itself. There is unfortunately no idiopathic, cure itself. We can only maintain the state of the patient. However, in other cases, probably around 5 or 10% of the cases of hypertension, we can find a reason for the hypertension itself. And primary aldosteronism is the most common cause of the secondary hypertension. Please note 6% of the patient is reported in the data, and up to 20% if we take only the patient with so-called resistant hypertension. So this is the cause that must be searched and must be found when it's there. Unfortunately, there is there are more things than hypertension. Aldosterone itself is, let's say, related with pro-inflammatory and pro-fibrotic effect of the vessels of the heart and the kidney. So we can find are more than 2 times more often myocardial infarction if the hypertension is related with high level of aldosterone. We can find more than 4 times stroke in case of hypertension related with aldosterone, and more than 5 times more often atrial fibrillation. What is the burden for the patient? Here is, let's say, a huge registry data. They are not really huge registry. The largest registry itself is with a little bit more than 200 patients. However, we can see that the number need to treat if we have a patient with lateralization of hyperaldosteronism and we perform aldosteronectomy. It's around a number need to treat in a patient for TAVI candidates, number need to treat for CABG patient, and actually what is more important, these patients are younger, and this patient has a quality of life effect. So this is only one reason that we must search for them. Which patients are really candidates? First of all, when we discuss this method, it's really the golden standard. We have nowadays 2 more methods that have higher sensitivity and also specificity, and you can see them in the bottom of the screen. However, we need cyclotron and let's say very special substrate. First of them is iodine marked cholesterol, and these methods are not widely available worldwide. So in most of the guides, actually renal vein sampling is the method that is preferred and cited as golden standard. So we must look for the patient with resistant hypertension, patient with a family history of hypertension, patient with early stroke, especially patient with stroke below 40 years old, with no other reason of them, hypertension that is related with adrenal adenoma, hypokalemia, or obstructive sleep apnea. Here is the algorithm in 4 steps. First of them is taking the aldosterone to renin ratio. This is taken from peripheral vein. Actually, the cutoff value is set to 30, and below this value the result is normal, so we must stop at step 1. However, if the result is above this value, we must go to the step 2 to confirm if the anatomy of the patient. CT is far more better compared to the MRI. Why? Because CT is better for detecting adenomas that are smaller than 1 centimeters in both sides. But when we look in the CT, we must remember that majority of the adenomas that we see on the CT are not non-functional. So they're not related with the hormone secretion. So the CT scan, unfortunately, is not enough for us to have, let's say, good data about that if we have or if we don't have lateralization. And here is actually the renal vein sampling. What is, let's say, a little bit more specific. First of all, stop all the drugs. This is all the drugs that are related with renin or aldosterone. This is very difficult, especially for this population of hypertensive patient. However, probably the best things are doxazosine and diltiazem available here, and also hydrolazine. It is better to perform the procedure at the morning, and you can see that there is a specific inhibition drug that can be used during the procedure, but is not mandatory. The procedure may be done without this drug. It's not available in Bulgaria. So why we need a CD? It's important not to have, of course, carcinoma, and it's better if the CT is enough in order to see the right adrenal vein, because it's a little bit more specific. Here you must note, you can see all the drugs that are related with renin and aldosterone ratio. Some of them, both of them makes the level of renin higher and the level of aldosterone lower. So also please note NSAIDs, which are, let's say, a little bit more popular among the patients, must be stopped a week before the procedure. So about the procedure itself, the specific thing is the right vein. This is the game changer, because it's small, it's short. In most of the cases, it's the direct branch of the vena cava. And these are the bad news. The good news are that nowadays we know from the registry, here you can see a study with 170 patients with adrenectomy that found that more than one renal vein, which is very challenging case, is very rare thing. And we have another CT study that among 18 patients, there is no patient with more than one adrenal vein. So when we find the right vein, this is enough. And this is the recommendation right now. In most of the cases, we use femoral approach. Per approach is also possible, but femoral one is, let's say, easier. And Simmons 1 catheter as initial catheters. However, we can change it if it's necessary to all these 5 additional catheters that we use. What we are looking for, we start with the right one because it's most challenging, and we are trying to, let's say, shorten the time between the samples, left and right. What we must look, actually, there is a typical finding that is this triangle of spidery vessels that are located over the adrenal gland. If we found inferior emissary vein is the most pathognomic finding for the, but it's not mandatory to be seen at any case. And here is one of our patient, which is the hypertensive patient with far more than 30 A error and CT performed before the procedure. Here you can see the suprarenal vein that is, let's say, cannulated with the Simmons catheter in this case. For the left vein, the things are very, very simple. Suprarenal vein actually drainates into the left renal artery, and there are nowadays more publication that there is no difference between the concentration into the suprarenal and the left renal vein itself. So you can take the sample from the both of them and to expect to have the same results. So when you catch the right one, the left is, let's say, the easy part that must be done in, let's say, less than a minute. And of course, I'm not an endocrinologist. However, I just choose these three indexes that are very important for us. First of all is selectivity index. If you measure the cortisol level from the adrenal vein, left and right one, and compare it, divide it to the cortisol level from the iliac control vein, and you have a result that is more than 3 times higher into the adrenal level, this is actually a good sign. Otherwise, the selectivity index is very low, which means that probably your sample is not taken from the adrenal vein, and this makes all the study to go on. And the other one, of course, is so-called waterization index. We use the first one. The second one is related with suppression with this drug that we doesn't have. And this waterization index must be more than four times left compared to right in order for the adrenalectomy to have a sense for the patient. Because if we actually have a secretion in the both suprarenal arteries, the treatment is, of course, a good no, spironolactone, etc. Thank you very much for your attention.
Are there any questions?
I'm curious, why not embolize the adrenals? Why you need to take them out by surgery?
I didn't have any experience with embolization. I didn't have any experience with the surgery at all. However, the surgery, I don't think the embolization itself will be possible and will be reliable, because into the gland itself, there are actually islands of cells that are hormonally active, and these islands are so small, and I'm not sure that embolization is possible. And
The literature,
It is possible, yes.
Probably, okay.
That can be done, yes, no problem. And so you have not to open the body, yes, only puncture an artery.
because if you consider Cohn syndrome, you have a typical adenoma and not hyperplasia. I think there are several, just a case series. I don't say that it's much an experience. I don't have personal experience either, but it looks like something which can be doable.
Okay, probably.
But
I
first we prove that it's they have lateralization, and then we go ahead and do whatever we do. Okay, thank you. And now it's my pleasure. I have a pleasure to listen a few times about treating coronary stenosis, and now Professor Matthias will tell us how to treat a coronary aneurysm, carotid aneurysm. Sorry.
Thank you for your mention. So, yes, aneurysms. What causes carotid aneurysms? Naturally, we have trauma. We have also some which, due to surgery at the neck area, with injury of the carotid artery, right down. And we have, besides atherosclerosis, other diseases, as you see, fibromuscular dysplasia, Takayasu, carotid dissection, myocardial aneurysm, radiotherapy, tumor invasion, and so on. So I have treated 41 patients with that problem. Most symptoms were pulsating tinnitus, and as you see, yes, hemorrhage is more or less rare, but nevertheless, when it's large, the aneurysm, it can also rupture. Yes, we have endovascular treatment options. We can place a stent with and without coiling of the aneurysm. And we can use endografts, so covered stents. You see here an example, wall graft, it's well suited for that, but also other examples you know are well used. So some examples. There you have an atherosclerotic ulceration. You see it here, that is during ultrasound, and there was also some already at the same site, a small infarction. Yes, and then you see, yes, how we can deal with it. With these aneurysm, you see only what is perfused by a contrast material field. Normally it's a little bit larger because you have there also thrombus and others, and you see that when we place the wall stent, yes, the patient was free of pain because originally he had a neck swelling with pain. And then another one, pulsating neck tumor again, you see, yes. That is the aneurysm, but you see also there is thrombus around it and edema. Fairly large, as you see. Also here, yes, with this pulsating neck tumor of this patient, yes, we did the angiography. You see it is a large aneurysm. And then we place the symbiote covered stent, and then the aneurysm is covered and starts healing. Here another case, carotid dissection with more than one aneurysm, two aneurysms. One is below there, and the other one is here. So a very large aneurysm and a narrowing of the carotid artery. You see it here again, and after we have placed a wall graft and covered it, yes, we could occlude it, and the patient lost his symptoms. Then a traumatic car accident. It was not immediately after the car accident, but 4 months later, he also had a pulsatory tinnitus. And he also had some other neck arteries which had an injury, because you see that the left vertebral artery is occluded and the right is also not normal. So he had really problems with his neck arteries. And we had also a problem because it was not difficult to reach the aneurysm, but to find, when we entered it, the distal part of the artery. That was not so easy, so at the end we found it, but we had done this curve. With this curve you cannot place an endograft. So we first had to move in a balloon, inflate it, and then we could pull on the wire and stretch it, and so at the end, when it was stretched, then you can go on with an endograft. And you see, yes, we placed a symbiotic covered stent, and now we have a normal artery, normal diameter, and no aneurysm anymore. Yes, here, cancer of the tongue. Also that can, it's rare, but it can affect the carotid artery. And there was also an aneurysm we treated in the same manner, was gone later on. That was after surgery, partial resection of the jaw, yes, also due to cancer of the floor of the mouth. Yes, so the surgeons, yes, injured the carotid artery, and you see, yeah, that is a very nice aneurysm there. Also here, with the wall graft, we covered this down here. You see the prosthesis there after rejection of a part of the jaw. Yeah, that's again a lady with a tumor invasion, recurrent laryngeal carcinoma. She already had surgery, she had radiotherapy, and now she started bleeding. We found this aneurysm that is well filled, but it's much larger. You see there only a faint contrasting. And also here, we placed the symbiotic stent, stopped the bleeding immediately, and had a final good result. Follow up, 7 months later, you see this stent there. Yes. So, sufficient. But then 7 months later, yes, what is this? We looked into the mouse, and the graft must be removed, but there might be still some blood flow in the graft. So the graft was nearly occluded, and then after ligation of the left column, we removed that endograft. But it was still partly open. Yes, then another 68-year-old man, carcinoma of the larynx, surgery, reconstruction of pharyngeal trachea, and radiotherapy. Yes, free graft function looks normal, but 2 months later, massive pharyngeal hemorrhage, CT, an aneurysm. It is here. Failed aneurysm. What to do? We decided to place a wall graft and cover it. And you see, yes, we did that. And we stopped the bleeding and had a good graft function. You see it here in this native image. Patient feels well after 5 months. And yes, the graft still works well. But then later on, you don't see there is no flow anymore in the graft, so that means it's occluded. And so the patient developed a hole beside the tracheostoma. So you see here the tracheostoma, and you see here a hole close by. No blood flow there anymore, because the carotid artery was occluded. So we looked into it, what to do without a stroke. So it was lucky that all the other brain supplying arteries had a sufficient flow and good collaterals. So we only pulled out the graft, as you see it here, yes, and then it was removed. Yes. Why does that happen? Yes, perhaps the stent graft was too stiff, perhaps, but the tissue also was already, yes, injured by surgery and radiotherapy. And so when you move your head all the time, then you have there some, yes, additional injury to the vessel wall. So our results, as you might see, more men than women. Atherosclerosis as a leading cause, but also carotid dissection, trauma, and post-operative with tumor. And yes, when we look at the results, yes, technical success was 97%, different grafts. We had later on 2 cases with occlusion. One I have shown you where we removed the endograft, and one had a recurrent aneurysm, needed a second intervention. 3 months to 7 years follow-up, you see that recurrence rate is low. Neurological deficit, we had only one with a minor stroke. The tumor patients, some of them died later on during follow-up because that were metastasizing and large tumors. So, thank you very much for your attention. Should you have some questions? No.
Sorry, no, wall graft is no longer in use, I think. Wall graft is no longer produced.
Yes, yes. So some of the cases are older cases. So I treated these patients over the last 20, 25 years. Yes,
If I got it right, no balloon expandable stent, only self-expandable stent.
yes, self-expandable because it's more flexible. That is the advantage. Yes.
Okay, thank you.